It's a real pleasure and, of course, an honor to be on this very august panel, and working with you, of course, at any time is a wonderful experience. So let's launch into this. Over the years, beginning in 95, we started doing outpatient fusions, 1 level, 2 level, 3 level, 4 level. And then when arthroplasties started becoming available, it was a no-brainer for us to switch to doing as many arthroplasties as possible when indicated, and moving them, it's the perfect outpatient procedure. So what I'm going to present today is a study that was published exactly 2 years ago in the International Journal of Spine Surgery with essentially 9 surgery centers with spine surgeons doing outpatient arthroplasty. You can see there's 11 authors in the 9 centers. And what I'll do is I'll review exactly what we did and what the results are. This was a retrospective study, 213 patients who had undergone 1 or 2 level arthroplasty. The indications are classic radiculopathy, arm pain and or neurologic deficit, with or without neck pain, or myelopathy, and the diagnosis of at least one of the following: disc herniation, degenerative disc disease, with or without visible loss of disc height compared to adjacent levels. And the study involved surgery that had at least a 6-month follow-up prior to enrollment in the study. And we did have IRB approval. This occurred between 2013 and 2015. Indications, as I mentioned, were very strict. We had failure of conservative treatment added in. So this was a sine qua non for our indications for surgery. And then the contraindications were the classic: no infection, no known allergy to the substances I listed in point 2 under the bullet points. The cervical instability had to be ruled out if there was any bit of luxation, spondy, no osteoporosis. And from my point of view, the most important was no severe facet arthropathy. Post-op care was standardized amongst the 9 centers. We ambulated the day of surgery, discharged from the surgery center 3 hours post-op. We restricted them for 4 weeks from lifting, bending, twisting. We sometimes, not always, prescribed a soft collar for use in a car, either as a driver or as a passenger for the first 4 weeks. All of us used an NSAID, generally meloxicam, for 3 weeks. The proscribed back to work schedule was minimum 1 to 2 weeks, and you'll see when I start presenting the data what really transpired. Physical therapy was generally offered for isometric strengthening at 2 weeks and dynamic range of movements only after 6 weeks. We restricted the patients from lifting. This is pretty much what most of us use in inpatients. So none of this is really different in the outpatient setting, other than, of course, the discharge from the healthcare center in 3 hours rather than whatever the usual was in a hospital setting. So what are our clinical outcomes? The results, as we all know, for arthroplasty have a lot of attractive elements compared to fusion. And indeed, our study didn't prove this, but this is why we did this study, because we believe in all these aspects of the positive outcomes for patients with arthroplasty. And I won't belabor this because this has been covered in other talks, and it's well known amongst surgeons. So getting right down to our data, we had 3 groups in our retrospective data analysis. The first group was pure ASC patients, 145 patients. We had hospital outpatients, also called HOPD, where the patient is operated in a hospital outpatient surgery center, not a freestanding ambulatory surgery center, and that was 348 patients. And the hospital inpatients were 65. More two-level surgeries were performed in the hospital than in ASC. And what's interesting and what you have to think about is the next list of numbers that I'm going to relate. Surgery times were significantly shorter in an ASC than either in the HOPD, hospital outpatient, or the inpatient one-level population. And you think, why? And that's why one of our titles was efficiency. So in the ASC setting, the average time for the surgery was about 63 minutes. The average length of time in the HOPD and hospital outpatient was 86 minutes. And in the pure hospital inpatient population, it was literally almost twice as long as doing it in the ASC. So efficiency, efficiency, efficiency is the name of the game here, proven with these retrospective data sets. In the two-level setting, it bore out in the same fashion. The two-level in the ASC was 92 minutes. In the HOPD, hospital outpatient, 126 minutes. And in the inpatient hospital, 140 minutes. Also, in the next set of data, you wonder why is our blood loss so much less in the ASC setting versus either of the hospital outpatient or hospital inpatient settings. And really, it's not just efficiency and speed, because speed equals blood loss. It's more time, more bleeding, and that's intuitive. But it's also the mindset of the surgeon doing outpatient surgery to be so careful with blood loss when you're outside of a hospital. So we had an average of 18 cc's, and there was a wide range there, but it was still very, very low. The mean was 18, and then that's comparable to the hospital outpatient, which was about 44 cc's, and the hospital inpatient, which was 86. And then in the two-level, it was similarly distributed between outpatient and outpatient ASC and anything in the hospital. So outpatient ASC in a two-level was about 21 cc's mean blood loss. And in the HOPD, it was similar for these two-level cases, whether they were in the HOPD, hospital outpatient, or hospital inpatient, about 67, 65 cc's. None of these patients needed hospital admissions, and there were no subsequent surgeries amongst any of these ASC patients. Now that's basically the substance of our abstract, and let's drill down a little bit more and get into the weeds a little bit, just to prove that our patient data sets, our demographics were very similar, and there's only one difference in all the factors that we looked at. Age, as you can see across the board, was pretty similar, 44, 45 years old. Male population in ASC versus hospital outpatient was slightly different, but pretty much the same as hospital inpatient. BMIs were about the same, 27, 28 mean. And then here's the big difference. Look at the workers' comp line. In the ASC, we had 20% of patients, labor and industries, workers' comp, versus 3% for the HOPD and 12% for the hospital inpatient, which was pretty interesting. And you ask why? Why were there more workers' comp patients in the ASC? Well, workers' comp favorably leans towards approval and non-denial of outpatient surgeries. They like it. It's less expensive, and they like their patients handled outside of a hospital where, as you'll see as we go through the numbers here, there's less adverse events. But what's interesting to me is what we'll see here in a minute, that when you take these workers' comp patients and do them as an outpatient in an ASC versus other sites of service, the return to work data was really different. And I'm going to go through that in a second. So let's just go through what we did here. We did the standard levels, mostly C5-6, C6-7, the numbers of one level versus two level. And again, intuitively, you can see how we flipped the percentages going from the pure ASC to the pure inpatient. So in the pure ASC population, we're looking at 2/3 of the patients being 1-level cases and 1/3 approximately being 2-level, whereas in the hospital inpatient, it's exactly opposite. And that's sometimes insurance, they're saying, no, can't do 2-level outpatient, and you have to use inpatient. And then as you see in the hospital HOPD, it's like almost 50-50, pretty close to equal numbers. So there was a little bit of an insurance effect there. It wasn't our telling the patients, if you have a 2-level, you need to be in a hospital. That's certainly not the case. So adverse events, you can see it's close to 0, if not 0, in the ASC population. In the hospital outpatient, extremely low numbers, and a little higher in the hospital, but within standard of care limits as far as what you'd expect for adverse events, and minimal numbers of secondary surgeries. Literally none in the ASC, 2 in the HOPD, and only 1 secondary surgery in the hospital inpatient. So pretty similar outcomes from that point of view, slightly better in the ASC population. The time I already went over, you can see these numbers a little more clearly here if you'd like. The time in surgery, I think, is very critical to adverse events. Quicker the better, as long as you're surgically proficient. It leads to less blood loss, less problems being under anesthesia for any prolonged period of time, and less other complications, bladder issues, pain issues for prolonged retraction, etc. All, I believe, less in the situation of an ASC surgery time of about an hour on the mean for a 1-level. So here's the return to work data that we found counterintuitive, but easily explained. You'd think that these workers' comp patients who want to and whose insurance coverage wants them to have surgery in an ASC, but look at when they return to work. It's not as good as the other populations. So if you look at the bottom line for each category, 1-level, 2-level, particularly 2-level, return to work 38 days after, on the mean, from an ASC, whereas hospital outpatient was 24 days and hospital inpatient 26 days. So why was it longer in the ASC? And the only supposition here was that workers' comp patients in our literature are well known not to return to work as quickly as a non-workers' comp patient. There's less incentive, particularly if they're getting disability payments, and also their job descriptions are such that it might preclude them from us returning them to full-time work because of the lifting limits that we put on the patients and working overhead limits and cervical extension limits that we put on. So you'd think that they would be able to get back to work quicker, but in reality, it's still fine, but it's longer than the other populations. So discussion of these results, it's pretty clear the safety is there, the efficiency is there, the lower incidence of adverse events and secondary surgeries in an ASC versus a hospital, shorter duration, less blood loss, really no red flags that what 9 centers were doing, moving all as many arthroplasties as possible to the outpatient, was in any way unsafe. And at this point, it's the way we do most of our cases. I'm going to show you my numbers in 1 second to conclude my talk. There's no question I consider it the way to go. It's safe, it's efficient. I'm doing about 98% of my cases outpatient. But look at what happened. over the years. I started doing outpatient arthroplasties in 13, and then you can see an incremental increase in numbers over the years until what happened in 2020. There was a steep drop off due to the COVID pandemic where everything came to a halt for a couple months. And then we're back to it. And I don't know if we'll catch up, but there was a clear-cut incremental increase in 1-level and 2-level cases over the years. And this year would have been, over 100 cases outpatient. So on that note, I will say thank you. And I believe, Dr. Chapman, you probably have a few minutes for questions.
Yes, we all thank you very much for an excellent lecture and sharing your experiences with us. Having personally witnessed your operations, I'm so impressed with how things work. And this leads me to the obvious question. What is the true secret sauce? Is it superb patient selection? Is it a very tightly knit team that you have in a surgery center? Or is it the fact that a surgeon runs this operation rather than a hospital with its administrative overlay and more or less taking the surgeon into the role of a technician? So what's the true secret sauce in essence?
All of the above, Jens, and as usual, you totally outlined what the secret sauce is. I'll just elaborate real quickly because I do believe that your first point of patient selection is absolutely critical. And we make a science out of selecting the right patients and then educating them. And luckily now the track record is pretty well known in the community and even outside the community, where people are self-referring in, self-selected and appropriate. Once in a while I have to tell them no, too much arthropathy, can't do an artificial disc, we have to do a fusion. We'll still do them outpatient, but patient selection is critical. High BMIs are not as worrisome. Some comorbidities are not as worrisome as they used to be. So we tier it. If somebody's had a history of a stent and is on some sort of blood thinner, we'll drill down on that with their cardiologist or their PCP, making sure that we can stop their blood thinner for a while and still be able to do them. And we do only 1 and 2 levels. We don't do 3 levels or more. And I know some of our august panelists may do more than 2 levels. We don't. So we're really strict about our criteria, our patient selection, our patient education is really critical in terms of their expectations, goal congruence in terms of outcomes, limitations post-op for the 4 to 6 weeks. And then we get the ideal patients in the door. As you know, having met our anesthesiologist and talking with him, anesthesia is critical. That's the only point I'd add to your very complete list of what the secret sauce is. This is not just for any anesthesiologist. They really have to be skilled at intubating patients, putting them to sleep with minimal narcotics throughout the surgery and minimal muscle relaxant only for the intubation and not thereafter, and then being able to wake them up immediately at the end of the surgery, having them awake when they're going into recovery, and reliably being sent home at 3 hours with good pain control, number 1, no urinary retention, and no nausea and vomiting. So besides all the other factors, really good anesthesia is critical. And I think that probably answers your secret sauce question.
So I would like to challenge you, invite you, maybe we can do a field trip with SSF, and on one of our Tuesday nights, interesting case discussions, we can do a live tour of your surgery center and get a guided illustration by you and your wonderful crew, because it's really worth seeing. If Dr. Ziegler and the TVI crew are interested, and you are certainly interested, I'd love to spend an hour with you there to just see a live video cast. Would you be up for that?
My house is your house, as you know, and I'd be happy to do that.
So one final, very brief question before we switch to the lab. The really big elephant in the room is airway compromise. Rick Sasso and his team, great team also in Indiana, wrote a very interesting paper how there's still a lack of coordination of everybody in terms of rating and understanding secondary airway compromise. We actually just right now did an anatomy study, which is going to be published, which shows that it's actually not that much volume that creates an experimental model airway compromise. It's about 30 to 50 cc's in the retropharyngeal space. We also have a clinical paper coming with a score. So these are rare events, but when they happen, they can be absolutely catastrophic. Very briefly, outside of excellent hemostasis, share some of the tidbits that you are doing to your staff and to the patients so that they can screen and respond adequately if this unthinkable no-no event happens.
Right. So I'm going to start with the end comment first. That is, I've done over 5,000 to 6,000 outpatient anterior cervical surgeries over 25 years, and I'm knocking on wood. I have never had a hematoma. I've never had to open a wound.
I'm knocking on wood. I'm knocking on wood here.
Yeah, exactly. I'm superstitious too. So I'm extremely cautious, like all of us are, the audience, all the speakers, we're all cautious, and it could still happen. It can happen when I go back to work, next week. But what are the tricks we use? First of all, we make sure people are not taking ginkgo, fish oil, NSAIDs, anything that could cause oozing in the wound. We certainly stop any significant blood thinner for 3 to 5 days, just depending on what the blood thinner is. And then that's pre-op. And then when we're in surgery, meticulous hemostasis throughout the procedure. And then I think what I'm going to say next is one of the key take-homes for the audience, because probably to this day, most people don't hear of this in residency or fellowship or even afterwards. And we wash out the wounds at the end of the surgery after getting complete hemostasis, no single red blood corpuscle visible in the wound. We wash the wound out with half-strength hydrogen peroxide. This is like from battle days, wartime, where they, stop bleeding in the brain, pouring in hydrogen peroxide. It stops bleeding, and it stops a little bit of oozing that might be subclinical from bone surfaces that are exposed or a little capillary leakage somewhere that might open up. This works. The wound turns kind of a whitish, and you can see very clearly before you close that there is absolute hemostasis. In the rare cases where it's not, it would be in a 2 or a 3 level ACDF more than an arthroplasty, because what I'm going to tell you is that we still use a drain once in a while in a bigger ACDF case, 2 or 3 or even 4 level, because there is just inherently more oozing in those cases when you take down the bony end plate, which you don't do in an arthroplasty. You preserve the bony end plate, so there's less bleeding inherently. So the half-strength hydrogen peroxide is a take-home. I find that it's extremely valuable, and I believe it's saved people having hematomas. Otherwise, we have not had any other reason for an airway compromise, edema, or other cause.
So one last question, I lied, but our friend Balaji Purushothaman, I think he's from Jakarta, asks, do you ever use drains in your outpatient surgery center? Let's say despite this half-strength peroxide, which I didn't see when you did that. You withheld that trick from me when I visited, but I'm going to use that.
I made you turn your back.
But do you ever find yourself using a drain for an outpatient then in your ASC? You just have done everything and there's still an ooze.
Not the arthroplasties. Fusions, once in a while in a 2 level, more frequently in a 3 or a 4 level.
So, Dr. Ziegler, we just got confirmation from SSF. They're glad to do a field trip. I'd like to volunteer to be with them to visit Dr. Wohns' center on a Tuesday evening. Jack, are you up for that?
We're happy to go along with you digitally. Absolutely.
Thank you for offering that or being offered that and responding favorably, and a great lecture.
Thank you.
Always learned a lot from you, and again, great insights. Thanks for your participation.
Thank you, Richard.
Thank you very much.